Kia ora koutou. Thanks everyone for joining us today. It's great to have you here for the 5th Evidence to Practice session. I'm going to start our session today by calling in positive energies for the hui. Tu taua mai I runga, tu taua mai I raro, tu taua mai I roto, tu taua mai I waho, kia tau ai te mauri tū, te mauri ora, ki te katoa. Haumie, huie, taiki. Well, thank you for joining us. It's great to see you here. Ko Cheryl Han tōku ingoa. I'm Chief Advisor in the Te Puna Aonui Business Unit and really happy to be the facilitator today. Before we get started, I've got a few messages. In this version of Teams that we're using, for those of you who are new to this, you will only see the presenters, but you can ask questions through the Q&A function at the top. So we're asking you if you could do that during the session. You won't be able to screenshot, or we ask you not to screenshot or independently stream, but there will be a recording of this available after the session on our website and on our YouTube channel. Today, we're really pleased to welcome Professor Silke Meyer from the Griffin University in Queensland, Australia. And she's going to be presenting for about 20 minutes or so on her research on screening for the perpetration of family and domestic violence. Then you'll have a chance to ask questions, and that will be facilitated by Sati Eti, who's one of our national system practice leads in the Te Puna Aonui Business Unit. The Q&A will be public, and so people online will see it, and we'll get through as many questions as we can. We're really pleased to have this conversation about recognising and responding to people who are using violence, because just recently Te Puna Aonui has published the Family Violence Risk and Safety Practice Framework that is about benchmarking the organisational procedures and the knowledge and skills for kaimahi that are required for an effective response to family violence risk. So just a reminder that we want this to be a safe and inclusive space. These sessions are going to cover issues to do with sexual violence and family violence, and that could be difficult or distressing for some people. Please do what you need to do to look after yourself and get support if you need it. We've posted the links to help portals and places where you can get more information about services and support. So now I'd like to introduce Professor Meyer, who is the Lenin Board Chair in Child and Family Research and Professor of Social Work at Griffin University in Australia. She's a criminologist and a social worker by training, and her research centres on different forms of family violence and domestic violence. And she also delivers training on these forms of violence to police, magistrates, family law and healthcare practitioners. So, Silke, I'll hand over to you, and thank you so much for joining us today.
Thank you very much, Cheryl, for the very warm welcome, and also thank you for the invitation to be part of this webinar series. Very excited to contribute to the first 2025 event. All right. Welcome everybody. As Cheryl said, I'm Silke Meyer from Griffith University, and I've been conducting research on domestic and family violence, including victim survivor help seeking and recovery, as well as men's use of violence and the impact on children and families more broadly for the last 15 or 16 years. And prior to that, I've been working as a social worker in different kind of practice settings that weren't necessarily domestic and family violence specific, but kind of had domestic and family violence always somewhere in focus, I guess, in terms of intensive family support services and out-of-home care and children's and young people's lived experiences. Before I start, I want to acknowledge the traditional custodians of the various lands from where we're joining on either side. For me, that's the Yagara and the Turrbal people in Mianjin in Brisbane. And I want to pay my respects to elders past, present, and emerging, and recognize that for me here, this land always has been, always will be Aboriginal land. Just to give you a brief overview, I'll just touch on some background in terms of some of the reform work in Queensland and Australia more broadly in terms of shifting the focus from victim survivors to people using violence and some of our interventions around domestic and family violence. And then, as Cheryl said, draw on the Queensland study findings that I conducted with 2 colleagues from Monash University in Victoria, Australia. And I'll wrap up with some key takeaway messages, and then I'm looking forward to your questions and having a discussion. So Australia, probably over the last 10, 15 years, has seen a lot of reform work across different jurisdictions, and some of it at a national level, led by the Coalition, but also the Victorian Royal Commission into Family Violence probably led the way with a lot of reform work that has filtered down across other jurisdictions. Queensland had the Not Now, Not Ever inquiry and task force in 2015 and released a large body of reform work and recommendations. And then more recently, Queensland also had the Women's Safety and Justice Task Force that has further informed reform work around violence against women and girls, and in particular criminal justice system responses. We've got a national level priority policy, which is the National Plan to End Violence Against Women and Children. The 2022-32 plan is the successor plan of the previous decade, which has, as I guess, one of its ambitious goals to end violence in the next generation. And I think this is probably the first time in the federal level priority policy frameworks that we've seen that shift from, while it still has pillars that are focused strongly on victim survivors, on prevention, on early interventions, and on recovery for both child and adult victim survivors, it has a pillar and a strong focus on working with people using violence. In the national plan, it's not solely focused on men, although it recognizes a very clear gendered framework in the policy and also the funding commitments across the states and territories. I think in the practice on the ground, we've also seen a big shift in expectations, moving away from placing a lot of the onus on victim survivors to manage risk and safety, and to focus more, and I guess also alongside that, from a government perspective, invest more in perpetrator accountability and support mechanisms for behavior change. I think in terms of the working with people using violence or men using violence, this still largely relies on the risk assessment and accountability of or interventions with people who've already been identified as perpetrators of violence or alleged perpetrators of violence. So a lot of that work still relies heavily on our men's behavior change intervention programs across states and territories, and to some extent relies on law enforcement and criminal justice responses. I spent 3 years on the when the Queensland's first Domestic and Family Violence Death Review Board was established in 2016. I spent 3 years on the Death Review Board. And I think one of the things, and that's what informed this research project, one of the things that we repeatedly saw was that people using domestic and family violence are not invisible to the service system. They very often have quite extensive and often diverse service system contact, but very often their use of violence remains invisible because the service system contact is around presenting issues, around I guess surface level symptoms, whether it's mental health concerns, whether that's health concerns more broadly, and GP contact. The healthcare system is probably one of the most common points of service system contact for people using violence, where there's opportunities to identify and support, but where the point of contact is not necessarily because of the use of violence, and use of violence may not be disclosed unless practitioners are being curious and are asking a range of different questions. I think when we look at, and we found that to some extent in the study, but when we look at the wider evidence, I think one of the major challenges for practitioners often is the concern that denial is a major issue when screening for use of violence, and that practitioners often feel that why would anybody who's not coming into the service system for anything specifically associated with domestic and family violence, but rather to seek alcohol and other drug-related support, mental health support, because they have to report to probation and parole, for example, why would they disclose use of domestic and family violence? But we've also known from the wider evidence and the practice base more broadly that denial is also an issue for screening victim survivors, and we still do it. And in several settings have at least recommended screening practices, if not mandatory screening practices for victimizations. And we know from a victim survivor perspective that there are many reasons why victim survivors may choose to deny victimization experiences, including shame, stigma, fear of retaliation, but also fear of statutory interventions that they're trying to avoid, for example, from a child protection perspective, when we're talking about mothers experiencing domestic and family violence. So I think there's an argument for screening male service users for the potential use of violence, particularly in settings where we know that we have a high level of overlap or correlation, which includes drug and alcohol use, mental health concerns, childhood trauma, so to some extent also, private mental health support settings, criminality, so corrections settings, and the child protection space in particular. And that's what we focused on in the study as 4 key areas to identify how practitioners, I guess, perceive opportunities for screening, what the practices are, and what supports practitioners in being curious and having conversations, even if there's no standardized screening tool available, having conversations with male service users about their potential use of violence, to identify risk to anybody else who may be involved in the family setting, but also to create opportunities for referral pathways and support for behavior change. So when we look at the intersecting systems, I think some of the things that frequently come up either in the research about intersecting support needs and or in the death review work that we've done on the Queensland Domestic and Family Violence Death Review Board, that very often people using violence, and that it probably doesn't even matter when you look at the middle circle, whether we're talking about intimate partner violence specifically, whether we're talking about domestic and family violence in a broader family context, or whether we're talking about adolescent use of violence in the home, for example, that families and individuals tend to touch points with multiple of these service systems, whether we're talking about public health or private and allied health services, disability services, mental health, drug and alcohol, the various points of law enforcement and the criminal justice system, housing and accommodation services, Centrelink, and parenting or child protection matters. So there's, I guess, multiple opportunities because we know that people using violence tend to come into these service systems and are overrepresented in these service systems, but won't necessarily disclose use of violence and related support needs unless being asked the right questions. The other thing I want to touch on quickly is language and how and why language matters. And this also comes from one of the Domestic and Family Violence Death Review Boards. That language matters based on how identified, whether it's experiences of violence or use of violence, when identified how this is articulated, how that is articulated in case notes, in referral notes, for example, anything that minimizes or neutralizes language, minimizes or neutralizes behavior, violent behavior. For example, when we talk about toxic relationships, domestic disturbances or situations, relationship issues, communication issues, anger management. This is language that minimizes. It's language that very often neutralizes and at least then partly blames the victim survivors, minimizing the perpetrator's choice to use violence, and distorts the reality of lived experience, both for adult and child victim survivors in the context of domestic and family violence. And I think particularly when I do training, we often talk about the importance of making notes, because notes inform the next point of service system contact, whether it's within your own service system and health practitioners, for example, making notes, and during the next healthcare appointment, another healthcare practitioners picking up those notes, or whether it's in referral pathways where notes on behavior may be shared between police, legal practitioners, courts, family law proceedings, potentially child protection. And that this highlights that documenting and identifying in particular patterns of behavior is important, because it informs how the next person picking up the case, the individual, the support mechanism responds to based on the information they receive. So I'm going to talk about some of the findings from the study, which had a national component, but I want to specifically talk about the Queensland component, because for the Queensland component, we had the participation from 4 different kind of government service areas: child protection in Queensland, corrections, and health with the AOD, and mental health, public health areas. And as I said, this was a collaborative project with colleagues from Monash universities. I want to acknowledge my colleagues, Dr. Kate Fitzgibbon and Dr. Nicola Helps, who worked with me on this project. And the key questions we had, both in the quantitative and the qualitative data across the survey and focus groups, were what kind of screening practices practitioners reported and what kind of perceptions they had about it. If they identified domestic and family violence use among male service users, what kind of risk assessment practices did they utilize, and what are the key barriers and enablers to identifying and responding to domestic and family violence perpetration. So I'll primarily focus on those barriers and enablers today. I'm happy to send Cheryl a link to, there's 2 publications available from this project if anybody is interested in some of the more detailed survey findings, for example. This is just a brief overview, and I really just want to highlight this because having access to training played a key role in a number of the barriers and enablers. But we asked practitioners whether they had received or accessed any kind of domestic and family violence specialist training, not specific to use of violence, more broadly domestic and family violence specialist training. And we had almost a third of practitioners who said they've never had any training in relation to domestic and family violence across these AOD, mental health, corrections, and child protection service settings. We had just over a third that said they had undertaken a short course, and then followed by 21% who had internal professional development. So for some, that was an online module that was compulsory either at commencement of working in that specific department or repeatedly on an annual basis. And then a relatively small proportion of people that said they had actually had access to a single standalone undergraduate unit or a postgraduate unit, or had actually completed a postgraduate degree. where we now have multiple universities in Australia who offer postgraduate certificates, diplomas, and masters in domestic and family violence related practice. So moving on to the barriers and enablers, and there's probably 5 key areas or themes that came out of the survey as well as the focus group interviews. I'm going to go through some slides with qualitative data that highlights the voices of practitioners. I won't read out all the quotes. Cheryl will be able to circulate the slides afterwards. So for more detailed information on how people articulated the different themes, feel free to have a look at the slides later. I really just want to touch on some of those themes. So in terms of domestic and family violence as core business was one of the key themes that came out of the conversations with practitioners in the focus groups and across practice. So child protection representatives, mental health practitioners said that if they operated in a space where domestic and family violence identification wasn't seen as core practice, where leadership and the organization didn't create an authorizing environment where practitioners had the time and space to have conversations, excuse me, to ask curious questions in conversations, and to explore with service users whether there is potential use of violence, and if so, what some of the risk assessment and support mechanisms could look like for the individual and potentially a family where there's a family attached to the service user. So practitioners who said in their area, DV was core business, even though the primary business is obviously child and family welfare or mental health of service users. But where DV was seen as core business, practitioners felt they had more time and space, more support. They often had access to other people in their area of practice if they were unsure, if they wanted to run through any mapping of behavior, for example, or risk assessment. So those practitioners felt much more supported in identifying and responding to potential use of domestic and family violence. And the practitioners who said that within their organizational setting, DV was core business, were more likely to say that they had access to specialist domestic and family violence training. They were more likely to screen for perpetration of violence regularly. They felt they were regularly positively identifying perpetration when they were asking relevant questions. None of them had a standardized screening assessment tool for domestic and family violence in these generalist practice settings. And those practitioners also said that while they felt people using violence may be likely to deny use of violence, routine screening is still important to detect the risk and identify service user support needs around use of violence. Same for the domestic and family violence leadership. So across the different practice areas, mental health, corrections, and child protection practitioners talked about how while everybody on the front line knows that domestic and family violence is an issue for their service users, it can fall off the radar if it's not regularly reiterated and supported by leadership. And I think this really highlighted that I think we often invest in frontline practitioner training, like in the Australian context, for example, we have a lot of service settings where safe and together training is made available to frontline practitioners working directly with potential victim survivors and or people using violence. But the conversations with practitioners really reiterated that unless leadership had received the same kind of training and had the same kind of buy-in and understanding, and as a result support for its teams and its frontline practitioners found it hard to make domestic and family violence a core component of their assessment process. People talked a lot about domestic and family violence specific assessment tools. And while Queensland has a domestic and family violence specific risk assessment tool for victimization experiences. At the time of this study, there was no people using violence specific assessment tool. That's currently been developed, and my understanding is that it's being handed over to government in the next couple of months for implementation and evaluation, I guess, alongside it. But people talked about the challenges of having practice area specific risk assessment tools, so general risk of reoffending in the correction space, risk of child harm and neglect in the child protection space, risk of self-harming behaviors or suicide in the mental health space. And practitioners found it challenging that if there's no DV specific assessment tool, that those kind of questions or the focus on identifying use of violence can fall off the radar. I think the other challenge in the risk assessment tool space was that people talked a lot about the diversity of service users, and particularly from an Aboriginal and Torres Strait Islander service user space in the Australian context, that there are no culturally sensitive and culturally safe risk assessment tools available to them. And that they felt a lot of the, I think a lot of the mainstream tools don't quite capture the risks, the support needs, and the lived experience of First Nations service users. And then people talked about professional judgment. And again, this came up across the different kind of service areas, and that people felt while they would like to have a tool to screen for and risk assess around use of violence, they also recognized that professional judgment was critical. And I guess going back to the role of training, for professional judgment, people need to be educated, trained, upskilled to feel confident to ask curious questions about what may be the standardized questions in the risk assessment tool, and to be able to make a professional judgment, even if the risk assessment tool comes up as moderate, if there are certain things that come up in conversation that people have the confidence to at least seek conversation with other practitioners or team leaders, for example, around validating whether, if the professional judgment suggests that more needs to be done than what's come out of a risk assessment tool, to have that kind of space and opportunity. And the common risk assessment framework that's used in Queensland, that is now also introducing the people using violence component, I think if it was used consistently, it makes it very clear that there are standardized questions, but that professional judgment plays a role in every form of screening and risk assessment, whether we're talking about victimization or perpetration of violence. And the final thing, really going back to, because people using violence have touch points with so many different service systems, that people were saying this is really a whole of system question. We can't address this in a siloed response. We need to ensure that domestic and family violence becomes core business in terms of identification and referral pathways across the various systems, that there's a shared language across the different systems, and that referral pathways are available, so we don't have individual service system responses that identify, but then have nowhere to respond to because the service system doesn't facilitate a holistic response. So just in terms of summarizing some of the factors that are promoting proactive screening and risk assessment practices, domestic and family violence specialist training certainly came up as a key factor because it gave practitioners skills and knowledge and confidence in asking curious questions, using certain kind of assessment questions, and also confidence in being familiar with the service system landscape and knowing where referral pathway opportunities exist and where the limitations may exist. And I think one of the things that stood out to us from a research perspective was the importance of recognizing that specialist training needs to be initial when practitioners start in a certain kind of practice area, but also ongoing, because we need to recognize that there's changing and growing evidence around priority populations, for example, around young people's use and experiences of violence, around cultural diversity, but equally recognizing that we're very often talking about fast-paced, busy work environments, particularly when we're talking about the child protection space, where we tend to have a high staff turnover, to recognize that training needs to be offered repeatedly and ongoing to ensure that the recognizing that the rotating or changing staff base regularly has access to upskilling and education opportunities. And then, as I said, really, organization environments making domestic and family violence core business, having both frontline practitioners, but also middle and top leadership, having had access to domestic and family specialist training to ensure there's buy-in and promotion of domestic and family violence identification and responses across the different level of leadership, to create an authorizing environment that makes domestic and family violence core business across a range of different service areas where we know that domestic and family violence, victimization and or use of violence tends to be overrepresented among service users. So really just highlighting some of the key takeaway messages in terms of the importance of individual perceptions, knowledge, and skills. Some of that goes with training, but also supporting individuals to ask curious questions, to have the time and space via an organizational environment and organizational leadership that essentially creates an authorizing environment for practitioners. Because I think practitioners across a range of different service settings recognize that domestic and family violence is a key issue that affects many service users. But if practitioners aren't supported to have the time and space to identify and respond, it falls off the radar and it remains unaddressed and unidentified. Because we know from research and other investigations that men who use violence tend to have multiple and diverse service system contexts. Oops, sorry, didn't mean to jump ahead there. We have multiple opportunities to identify potential use of violence and to support individuals and families around that lived experience of use of violence and related victimization experience. And just really highlighting the shared language and holistic responses, because that's where individuals tend to fall through the cracks when we have a service system that doesn't have a shared language, that doesn't have a shared approach to identification and responses, and that is unable to refer on or refer out or offer a more holistic response to the diverse and often complex support needs of people using violence. And then finally, just what I initially started out with in terms of language matters. So it is not just about identifying and recognizing, it is about how we document and articulate the identification of use of violence, particularly with regards to patterns of behaviors in relation to domestic and family violence, to inform subsequent service system responses and interventions. Thank you very much. I might stop sharing.
Silke, thank you so much for sharing your knowledge, insights, and passion with us this morning. Your presentation has shed light on how crucial it is to shift our focus from placing the burden on victim survivors to holding perpetrators accountable. I truly appreciate the clarity and urgency you bring to these issues. Wearing my practitioner's hat, I believe in the value of refining the ways we identify and respond to perpetration effectively. So with that in mind, I'd love to explore, and I suspect a number of other practitioners who are attending would love to explore and delve a little bit deeper into your insights. I wouldn't mind starting at a broader perspective in terms of you highlighting the importance of making perpetrators rather than victim survivors central to our interventions. Could you talk about why that's so vital and how organizations can achieve this shift in a way that's safe for everyone involved, please, Silky?
These are very good questions, Sati, and big questions. I think it's vital because it creates opportunities for change. Because I want to say, for the vast majority of people using violence, that use of violence is a choice. Changing that kind of behavior may require a range of support mechanisms. Like, I think I want to recognize that there's a role for therapeutic accountability work, because I think very often we talk about intergenerational experiences and use of violence, and the other, I guess, contributing risk factors of drug and alcohol use, mental health issues. But I think we still need to centralize in conversations with people using violence that it is a choice to address that. You may have underlying experiences that contribute to use of violence that make it difficult to just stop using violence. But it is, I think there's accountability around being willing to do the hard work with the kind of support that the service system has to offer, whether that's from an, drug and alcohol intervention space, mental health, therapeutic work, or some of the, more therapeutic or healing focused men's behavior change intervention. So, recognizing that there's diversity in men using violence and that men may use violence for different reasons, and that it may be harder to change that kind of behavior for some than others. But where we have those support mechanisms available, I think it is important to place the onus on the person using violence, and place the onus on that person to make the choice to do the uncomfortable work, I guess. I think you're right. We have, I think there's much more familiarity and less concern or fewer barriers to working with men and doing the tricky work in the sector that's trained to do that, like the men's behavior change work. And, recognizing from a social work perspective, this is hard work. I mean, it's uncomfortable work and it's hard work facilitating men's behavior change programs, holding people accountable. And so I think I can see the barriers for practitioners who sit in other areas where they may have had some professional development in terms of internal units or modules for domestic and family violence, upskilling, I guess, which is certainly not enough to do men's behavior change interventions. So I think I would like to look at it from a practice point of view, that there's an opportunity for everyone to ask questions and to identify without having to challenge the behavior in a way where it may create uncomfortable scenarios that a practitioner is not trained or equipped to manage. I think one of the challenges often is that we think of men using violence as dangerous. And I think there's that kind of barrier that, I know a lot of the child practitioners that I've spoken to over the years across different studies, have said these men are scary based on what we know, what the victim survivors have experienced, what police reports have done or have communicated, and that practitioners often don't feel equipped to, I guess, confront. So I think the expectation is not for every general service area to have practitioners who become experts in men's behavior change. But I think there are opportunities, and I think the research, particularly in the health space, the research shows that men are willing to have a conversation, or they may deny. I think, and I think the other thing to remember is that very often men using violence are very good at image management and manipulation. So the kind of level of aggression they tend to display in the family home where they're comfortable to do so is usually not the level of aggression that they would display in a conversation with their GP or a mental health practitioner, for example. I think the kind of settings where it's more likely to see a level of aggression are probably the kind of settings that are used to that anyway, that kind of resistance to engage in the corrections and, probation and parole space, for example, the child protection space. Like, I don't want to minimize the experiences of practitioners there of, working with tricky situations where people may become irritated and aggressive. But I think those practice areas are probably equipped to deal with that kind of level based on the kind of service users they are working with. So, yeah, sorry, you were saying, how do we do that safely? I think it is about offering conversations. One of the things, like we evaluated child protection-based intervention a few years ago, which was called Walking with Dads. And we interviewed some of the fathers who were, I think the focus of that intervention was to shift from holding mothers responsible for protecting children from domestic and family violence and bringing fathers who use violence into the conversation as the person accountable for the child welfare concerns that have been notified or detected. And a number of the fathers we interviewed said, this was the first time anybody ever asked me. So I think it's about creating a safe environment where you can have conversations about, how do you think this is impacting your family? How do you think your children feel? Even though, the person using violence may say, I'm never using violence towards my children. It's, it's intimate partner violence and it's between my partner and myself. But I think the fathers appreciated questions like being asked in a safe setting, what kind of father did you want to be? What kind of opportunities are there? What kind of support do you need to be the dad you want to be? And men saying, it's the first time anybody ever asked me that. So I think we underestimate that at least some people using violence want to have a conversation. And I believe from having done a lot of the men's behavior change program evaluations that there are a lot of men using violence who want to not use violence and who want to do better and who want to be a better dad and who want to be a better partner or who want to have a healthy relationship, but have no idea how to, for a variety of reasons. And, and I think then we have the other end of the spectrum where we have highly manipulative, controlling, educated perpetrators who know very well what they're doing and who will use the system to their advantage. I think that's maybe the other thing from a practice perspective is to always be curious and, I think to not feel overly confident that you're able to identify a person using violence. Because I think when we're talking, I think there's perpetrator populations where what you see is what you get, and who will probably also be quite forthcoming about the intersecting issues that I've talked about in terms of struggling with drug and alcohol and or mental health issues and or childhood trauma and use of violence, and then there are people using violence who know how to image manage, and I feel like having interviewed many men over the men's behavior change program evaluations, it's easy to fall into the trap of taking at face value what people using violence have to say. And if you have no reference point, and I recognize that for certain practice areas, you may have no reference point because you have no contact with the victim survivor, for example. So you have very few opportunities to cross-check what somebody is telling you. But I think we have opportunities to open up conversations for those who want to have a conversation, and to create referral pathways for those who are willing to take up support. Like I don't want to say the service system has an opportunity or a responsibility to identify every single person using violence that comes into mental health, AOD, or child protection services. But I think these practice areas offer opportunities to open up conversations with people who, at least to some extent, are concerned about their behavior, even if it's for the wrong reasons initially, of wanting to avoid losing contact with your children or wanting to avoid a criminal charge or something, not for the, I guess, internal motivation to change behavior. But I think those conversations can create pathways to the shift towards internal motivations to do the hard work and work on long-term behavior change.
Love it. Thank you for a very comprehensive and nuanced response to that. And as someone who's worked a number of multiple roles as a probation officer and then working therapeutically with the men, I completely understand what you say in terms of there are aspects of the men that reveal themselves depending on what role and what context. Mm-hmm. So it absolutely makes sense to me what you're saying. I've got a question here from one of our practitioners online. Kia ora from Aotearoa. Are there any parallels with this research finding to research findings in Aotearoa?
A very good question that I may not be able to answer. And I wonder, Sati, whether you have, and maybe this is an opportunity to talk about the, the risk assessment practice framework in terms of, having worked, sorry to pass this question back to you, but having worked in, generalist settings like probation and parole, and having worked in the men's behavior change space, what's your take on the different practice areas where we know people tend to have points of contact, and I guess the sector attitude towards, is it core business in mental health or AOD services to identify use of violence? And, and I guess how open are practitioners, and to what extent are organizations and services behind it to create a space where it becomes core business?
I'm really reluctant to answer that. I'm not an expert in any of those to be able to answer that properly and fully. I can tell you though, and it's probably relevant, this conversation, given that we've just released and launched, and I suspect Mary, who held the pen on the risk safety practice framework, but this is so relevant, what you're saying in terms of the importance of the response and practitioners being able to really formulate a response that's appropriate, but that's also within their lane. Because as you say, there are a number of practitioners that might enter the home, and depending on what their role is, if it's a police officer, one of the things that you've highlighted is being able to capture that information well. But you need to be mindful too that the police officer has its own primary response in terms of managing safety in the moment, right? Harm in the moment. So there are a number of things going on for them. So the conversation around capturing that information that could be passed to someone who will need that information in their lane, so someone who's going to be working with them therapeutically, it's really important that whoever's entering into that space, it's engaging with the users and victims of violence, are capturing information appropriately, which is a challenge given what they're having to contend with as a police officer or someone entering the home, if you know what I mean. So one of the things about the risk practice safety framework is that it allows practitioners to see where they need to be in terms of essential, entry, enhanced, an expert in terms of the kind of
Yes.
response that's appropriate. So
Yeah.
that's one of the powerful things about this particular framework. It allows practitioners, depending on what their role is, to actually have a look at what is the response that's appropriate for me as a practitioner, given that I might be, that this is the role, the lane that I need to be operating from, and mindful that I need to be passing it on to someone who is probably an entry or an enhanced. What's the kind of information that they need to receive in order to capture capture everything that needs to be captured to provide a full screening assessment? I'm not even sure whether I've answered or even contributed to the answer of that, Silke.
Yeah, and I think, I mean, that resonates with the common risk and safety, common risk assessment safety framework that Queensland has. Is similar in terms of, it's multi-tiered, and frontline crisis, non-DV specialist service would only respond to a section of it, as you say, because everybody, there's specific purposes for which different points of the service system capture information, because they have to do something with it, whether it is for criminal proceedings or for therapeutic interventions or around child welfare concerns. And, and the more specialist services complete a full comprehensive, assessment process. I think it is more like, I completely agree with that. And I think what we really don't want is, we don't want to expect that every frontline responder becomes an expert in domestic and family violence, because there's a lot of complexities out there that service users present with, and not everybody can be an expert in everything. And I find, when you come into training settings, often, people will say, well, I can't, we deal with mental health, we deal with domestic and family violence, we deal with child abuse, we deal with drug and alcohol use, we deal with suicidality. I can't be an expert in everything. And I think that's very important to remember. It is about, equipping practitioners with a baseline knowledge and understanding, and I think confidence of asking certain questions, knowing what to do with it, knowing where to go with it. Like, I feel like this is often an initial barrier for practitioners, and I've taught in, social work, nursing, midwifery, and Cheryl, I saw your comment. I'll come to that in a second around, university courses covering this or not covering this, of, students saying, when they then commence their placements and become, come close to graduation, saying, but if I identify and I don't know where to send somebody, what do I do with that? Then I'd rather not ask, because otherwise I've opened up a conversation that I can't support somebody around. So I think there's opportunities to do more work, probably holistically as a sector, of ensuring every practice area knows the service landscape. You don't have to be a specialist in domestic and family violence, but you should at the very minimum know who is your local or jurisdiction-based, or at least the telephone helpline point of contact that you can equip someone with who may disclose something. And who's the next point of contact around safety planning if you have safety concerns for someone. So I think, I think it's on organizations, but going back to Cheryl's point, I also think it's on us as universities and tertiary educators to ensure that, because it's the same over here, we have a number of study areas that still don't have domestic and family violence as a core unit, at least as a standalone elective for someone to do. There might be a lecture covering domestic and family violence or gender-based violence. And realistically, whether we talk about psychology, whether we talk about law schools, whether we talk about health, mental health, social work, by the default nature of those professions, there's a high likelihood that graduates will come in contact with someone experiencing and or using violence at some point in their professional career. And I think we're setting graduates up to fail if as tertiary education providers, we don't make that a priority in some of our degrees where we know research-wise there's a high level of overlap between service users in mental health, for example, and domestic and family violence and child protection, for example. So I think I take that point, Cheryl, that I think as universities, there's more we can do to equip practitioners to not place the whole onus on organizations and practice settings then to upskill frontline practitioners.
I'm wondering whether we have time for one more question, if that's okay, Silky.
Yep.
And this is a personal one for me in terms of something that stood out for me. One of the challenges that you mentioned was ensuring that frontline workers in different agencies don't minimize violent behavior by labeling them as relationship issues or communication problems. As a practitioner, I've seen how language can so easily shift blame and muddle accountability, right? Can you share your thoughts on the best ways to establish clear, direct, and accurate language when documenting and discussing family violence, domestic family violence?
Yeah, I think in part it is about that clear language of who is using violence or who is the primary person using violence, or whether, for example, someone's use of violence is in response to or in anticipation of experiences of patterns of abusive behaviors. And I think identifying patterns of behavior is another critical aspect to communicate to whoever picks up this information in the next instance or down the track, of whether something someone's disclosed or reported is part of a pattern of behavior or a pattern of experiences, or whether it was a one of out of character lived experience, for example. And I think maybe the other thing that's useful, and again, I recognize that maybe in a crisis response, there is less time to unpack some of those things, but where you have that opportunity, not just articulating whose use of violence, but also how this affects someone. And I think how it impacts someone, because I think we have different experiences, and sometimes the non-physical experiences of violence are minimized because we have this perception that it's more serious if there's physical force or physical injury involved. I think when we listen to victim survivors, it's very often that pattern of non-physical abuse that undermines sense of self, that undermines confidence, that undermines ability or I guess confidence to disclose or seek help, for example. So I think recognizing not just the experiences or the use, but also how that affects or impacts other people in the household. I think if you have the opportunity or the time to ask those kind of questions, to document that in case notes or in the system.
Wonderful. I'm mindful of the time. Silky Meyer, thank you so much for allowing us to dive deeply into the areas that you've explored with us. Your expertise and the evidence you've shared with us have been really invaluable, and I'm especially grateful for the way you've illustrated the many points of contact and cooperation needed across our sectors to ensure we're addressing family violence in a truly holistic way. So thank you so much. I'm going to hand it over to Cheryl. Thank you.
Thank you. Thanks, Silky, and thanks, Sati, for the great questions. I hope everyone found that really informative. I think we could keep on going for another hour. I love your focus on all of us having more conversations and keeping the visibility of people who are using violence and those early intervention opportunities, because otherwise we're leaving it to victim survivors and families and whānau to manage the risk. And I think that idea about all of us having a role is really important. So thank you so much for your time. It'll be on our website with the full video and the slides. If anyone wants to go and check that out again, and please send it to your colleagues. We're really happy that next session will be the Tuesday, the 20th of May at noon, and we're going to be welcoming Dr. Hedwig Eisenbach, who's at Victoria University, who's been doing some research from the Growing Up in New Zealand study and looking at the conduct problems for young children and the links with intimate partner violence. So make sure you get on our email list to get the invites, and I'll just close with karakia to send you on the path for a safe and productive rest of your day. Thanks for joining us. Kia tau te rangimari e ki runga ina iwi Aotearoa. Haumi e, hui e, tai ki e. Thanks, everybody. See you again in a few weeks.
Thanks for having me. Thanks, Cheryl.
Thank you.